What are some of the most common misconceptions about urinary incontinence among patients and or healthcare professionals? And then Julie will answer that same question.
You know, the I mean, we spoke about the patients and the unwillingness to talk about it. You know, there's only pads. You just have to put something in your pad. You know, you have to collect the urine with a pad, and you know that's what's available. And I think that's the misconception because you want to talk about it. So you look at it, and then you need to find who do I talk to, and that's another thing I can see. And culturally, it's very you know, where do I find the know-how? So you talk, you think you can talk to your normal family doctor about it. They might know something, maybe not. So here there is like a lack of. I think it's connected to from the patient side of view is that we don't talk about it. It's not on the table. We don't know where to go, and we only hear about the pads. They are huge companies. They advertise, and they have the Barbs and the Essities and all these companies. They're available all over. You can get them. So will deal with myself, and instead of trying to find out how can I manage this in a different way. So I think that's from the patient side. I think Julie probably has a better insight in this
Mhm.
than me. On the
Well,
other hand, on the healthcare, on the yeah, sorry, on
no,
the
no, I was going to
healthcare
say, I
side,
think you're right that urinary incontinence products are not the only way to manage UI, and I think that's a
yeah,
great takeaway from that. Go ahead. I
yeah,
didn't mean to interrupt.
yeah. No problem, no problem. So on the healthcare side, you know, it's the same thing. We have a catheter. You come into the ER, and you need to take a urine sample, and you put a urine catheter. You know, only 50% of the patients with symptoms of UTI, which is very common in elderly, and they can produce a midstream sample. You put the catheter in. Well, 50% don't have UTI, but you cause a UTI, a cavity, with putting the catheter in, and you just routinely put it in because it's an easy way. There's a stress and an easy way to take a urine sample. Well, you can now with a natural fit device, you can have an external catheter that actually takes the sample or takes it in another way. So that's available, and but to get it into the hospital, it's a huge challenge. The same with the pad. In the hospital, you just use the pad. Well, when you come home again, or you come to the nursing home, you have a pelvic sacroiliac wound because you routinely just put the pad in, you give the patient diuretics, they have a lot of urine, and they're wet. And so a majority of the wounds are created in the acute care situation. And when they come home or come to the nursing home, they have a pelvic wound and they have to go back in or have very costly treatment for that wound. So there is no strategy, and you need to change your routines. So you just don't give diuretics, and if you do it, you don't have enough care staff to turn the patient or change the diaper because you're not interested in incontinence in acute hospital. So that's an issue because you have a different goal. So integrating incontinence in the total care when the patient comes into the ER, when it's admitted, this is we have to get the status. Are they incontinent? What kind of incontinence? Just ask the questions and get it in, and it's part of the total care. So I think I think it's not a misunderstanding. I think it's a lack of understanding, if you could call it
Great,
like that.
great points. Great
Thank you.
points. Julie, you want to build on that?
Thank you.
Any misconceptions about UI and patient and healthcare populations?
First of all, just to reiterate that we are told it is normal. We're always envisioning elderly adults in diapers and such, but it is not normal. It doesn't need to happen. It's common. You're not alone, but it is not normal. Um, the whole thought about it affecting men and women equally, I will tell you in my practice, the younger population that I tend to treat are women, whether it's athletes or postpartum. And then as they get, and sometimes I'll have a few men who possibly had an injury or something along those lines, but as men age with the medications that are frequently given for uh, anything along the lines, and they're experiencing erectile dysfunction as well as incontinence. And like Dr. Cohn said, just based upon the prostate, as men get to that stage where they have either enlarged prostate or prostate cancer, that's when I start noticing an uptick in having men in the practice as well. But it does not just affect elderly people, and that is something that has been very isolating for the younger population, in that there are a lot of athletes that are wondering, why am I leaking as I am doing this? And there could, there's a whole host of reasons as to why this could be happening. And, it's important to explore those reasons and determine the cause of it, as mentioned previously. And, people think it will never be able to improve or never be able to be treated, but that's also not true. There are so many things that can be done. In my practice, if I have patient buy-in and the patient understanding, and if, let's also call it the big if, that if incontinence is really the only problem and that it is due to a weak pelvic floor muscle, um, we can truly help improve the patient's quality of life and decrease the incontinence within, you know, 3 to 4 weeks. They will start noticing a difference. So that could be super huge, in just in terms of giving the patient buy-in that there are things that can be done. But again, there are many different diseases, diagnoses, problems that can arise. So it's important to know the why and how to treat it, and not everybody can be treated the same way. Some devices may not work with that population or that specific diagnosis. That being said, there are things for everybody to be used. Uh, and then, just also, again, the stigma and the fact that we're not addressing it. And I feel like if there's one thing that we can all hammer home, it's address it, talk to the patients, talk to people, talk to your friends, talk to everybody, because there is no reason that you should be suffering alone. There is no reason a patient should be suffering alone. And if we can address this with them early on, then we can truly impact a person's life. And there is no reason that we should wait until it is a gigantic problem and the person is unable to leave the house, because as we know, it creates a whole host of other problems. With the decreased activity, you're going to have less muscle activity, and then they're going to be more weak, and then suddenly you're going to see all of these other side effects spiraling out of control, simply because a person is too afraid to leave their house because they are incontinent. And we could have worked with them to address it, whether it's given them a device, or whether it's giving them a way to retrain their pelvic floor, or a surgical intervention. There are so many things that can be done, that a person does not need to suffer.